This video will show placement of an external ventricular drain. The surgeon and demonstrator is Dr. Michael Horowitz from the Pennsylvania Brain and Spine Institute. This simulation was performed at the Butler Memorial Hospital Simulation Laboratory. Here a nurse is preparing the drainage system. Saline is being drawn up sterilely. All tubings will be flushed with this saline in order to prime the system. We are not showing absolute sterile technique because this is a demonstration in a simulation lab. Here the drainage system is being secured to a pole next to the patient's bed. The mannequin is seen in the background. Typically, the 0 point of the drainage system is placed at midbrain or above midbrain, either 0 to 15 centimeters above midbrain. The tragus of the ear marks the midbrain. Here the drainage tubing is being attached to the drainage system. Saline will be flushed through the system. Here's the patient, positioned approximately 45 degrees, sitting in bed. The patient is intubated. Here's the kit, which will contain everything needed for dissertion. The kit is opened and a sterile bag is found inside with a tray. The tray is opened, showing all materials needed for insertion of the external ventricular drain. The drain is separate. This is the mannequin without hair on. You notice that we are going to show the insertion site. We are measuring 11 centimeters posterior to the nasion. We will then measure 3 centimeters to the right of midline. This is approximately the mid-pupillary line. From this point, a line is drawn to the medial canthus of the eye, and another intersecting line is drawn from the insertion site to a point 1 centimeter in front of the tragus. Once these lines are drawn, the ventriculostomy will be inserted, superimposed on each of these lines. This will allow the tip of the ventriculostomy at a depth of approximately 5 to 6 centimeters to enter, in this case, the frontal horn of the right lateral ventricle. Here we see the lines drawn showing the trajectory of the ventriculostomy catheter, and here we see a metal probe lined up along each of these lines. And here is the insertion angle. We will now show this on the mannequin. Here's the mannequin with the hair in place. We are measuring 11 centimeters posterior to the nasion and making a point in the midline. We will now measure 3 centimeters to the right of midline, which is also the mid-pupillary line. The scalp is marked and shaved. A larger shaved area can be done to make the insertion lines more visible. This is 11 centimeters posterior to nasion. And now 3 centimeters to the right of midline, which is generally the mid-pupillary line. A straight line incision is drawn.
Yes.
The area is now prepped with betadine, and the surrounding hair is prepped with betadine. Once again, more hair can be shaved so that the lines shown previously can be drawn and the ventriculostomy aimed properly into the frontal horn of the lateral ventricle. A clear sterile dressing is now taken from the kit and placed around our incision.
You still filming, right?
Yes.
Any exposed hair and the scalp is once again prepped prior to insertion.
You can stop now.
By prepping properly, this can be done sterilely at the bedside and not in the operating room. Here we're using 1% lidocaine with epinephrine to infiltrate the skin. This is done at the bedside to control bleeding, as no electrocautery is generally available. A 2-centimeter incision is made in the scalp,
I am.
and the incision is extended down to the skull. An eyebrow self-retaining retractor comes with the kit.
Yep.
It is used to hold the skin edges back. Here it can be seen inserted to hold the skin edges open. The underlying skull would now be visible. We will now prepare the drill. Here is the drill handle, which comes with the kit. Here is the bit. The white device is a chuck that can be adjusted. We have slid it and tightened it to expose just enough bit to go through the skull. Here the bit is inserted into the drill and tightened. We will now drill a small hole in the skull. We try to drill this hole at the angle that we would be inserting the ventriculostomy. We slowly turn the drill and then start doing half revolutions until we feel the drill penetrate the inner layer of the skull. This sensation of penetration of the inner layer of the skull is from experience. The drill is now removed. The hole is irrigated with saline to remove any small bone fragments. Here is the ventriculostomy. It comes in a separate package. The ventriculostomy is removed. Each of the lines seen to the right side of the ventriculostomy tubing represents 1 centimeter. For a right frontal ventriculostomy, the insertion is generally made down to a depth of 5 to 6 centimeters with the inner table of the skull.
I'm good.
This is a metal trocar. This will be used to tunnel the device beneath the scalp at the end of the procedure. The sharp end is also used at the bedside to open the dura prior to insertion. Here the dura is being punctured. We're now ready to insert the ventriculostomy. The ventriculostomy is inserted using the coordinates and trajectory that were shown earlier. It's placed down to a depth of between 5 and 6 centimeters.
Yes, I am.
If no CSF is obtained at a depth of 6 centimeters, the device should be withdrawn, wiped clean, and an attempted reinsertion should be made. We have now inserted it into the ventricle and felt the characteristic pop as it crosses the ependymal lining. The stylet is now going to be removed, and we would generally then see CSF coming out of the catheter. It is drained a bit and now squeezed shut.
Yes.
We do not want to lose too much CSF at this time. If the patient is under significant increased intracranial pressure, we would allow more CSF drainage at this time before moving ahead. The metal trocar that was seen earlier has now been attached to the end of our tubing. It will be used to tunnel beneath the scalp
Okay.
and bring the ventriculostomy out through a separate stab incision in the scalp. We try to be at least 3 to 5 centimeters away from our incision
Okay.
as we exit the scalp to reduce the risk of later infection. Here we are tunneling underneath the scalp, and we will carefully bring the sharp end of the trocar out and through the scalp. As we bring it out, we will gently grab the proximal end of the tubing near the skull so that the tubing is not pushed deeper into the head as that knuckle of tubing becomes straightened. Here the trocar is removed, and once again drainage would be observed. We will now attach a white stopcock to the tubing. This will in turn ultimately hook up to the drainage system that was prepared earlier. The red end on the stopcock is a blind end that will block CSF from exiting until we want to hook it up with the drainage system.
I do.
We will now turn our attention to closing the scalp.
Yes.
The retractor is removed. Generally, when this is done at the bedside, a skin stapler is used to reapproximate the skin edges.
Okay.
Ready?
Here is a typical stapler. The edges are now stapled together.
Okay, stop.
Okay.
We will secure a Telfa dressing stapled to the head to keep it clean, and we will now use the stapler to staple around the tubing and secure it at 4 points to the scalp. This minimizes the chance that the tubing can inadvertently be pulled from the head.
Okay, keep us through that.
Okay.
Okay.
Where the tubing joins the stopcock,
Yes.
we will use a suture tie to secure it so that it cannot inadvertently become detached. Be careful when tying this knot not to occlude the tubing, but to make sure the knot and stitch are at the point where the tubing is on the white end of the stopcock. The red blind end will now be removed, and the external ventricular drain will be connected sterilely to the drainage system. The EVD, or external ventricular drain procedure,